for discussion's sake, would it be fair to then say that, these buzzwords of unmet need in this patient population? And I think my definition of unmet need is that unless we have cured everybody with zero toxicity and the drug is completely free, there's always going to be some unmet need. But not to get that theoretical, I think, do you think it's fair to say that I think the likelihood of a response is relatively low, while the clinical benefit rate reflected in progression-free survival is obviously decent, better than placebo, which is why the drugs got approved, but it is still limited. And this certainly comes at a price in terms of some of the toxicities that you already described. And I think it's important to point out to the audience that part of the problem is that some of these toxicities overlap with the symptoms of bulky tumor. So it's not just the drug, but it is drug plus tumor that makes it difficult for patients to tolerate some of these second and third line agents for a more prolonged period of time, which is what leads to some active research to try to find newer agents with better therapeutic index.
Yeah, I absolutely agree. I would add, though, that aggressive management of toxicity with these drugs is critical. And often can make these drugs more tolerable, as can be dose reductions for these medicines. And patients often do quite well with lower than labeled doses of these medicines. We try to get patients to the labeled dose, but if they can't tolerate it, then dose reduction is still an effective strategy for many patients. So as you described, that we want to cure patients. Reality is that right now we can't in the metastatic setting. Instead, we need to balance the control of the disease with the toxicity of the medications. Absolutely a need for additional treatment strategies. There's no question about it, to be both more effective, more durable, and less toxic. But I also don't want patients necessarily to be scared by us discussing the toxicities, where many patients are able to tolerate these medicines and have prolonged periods of disease control with them. The numbers you quoted are absolutely accurate, but they're the medians, which means that half the patients are doing better than what we described. So these, that's this progression of imatinib, sunitinib, and regorafenib is a very effective strategy and tolerable strategy for the majority of patients. But there's absolutely no question that we need better drugs for all the reasons we just described. I would also add the other areas of clear unmet need until recently were the D842V mutant tumors, PGFR mutant tumors, for which imatinib, sunitinib, and regorafenib do not seem to have any activity. And I think we'll come back to that shortly. And certainly for the SDH mutant GIST2, although the VEGF receptor antagonists do seem to provide some benefit, we need better strategies for managing that subtype of GIST as well.
You brought up a very important point of proactive management of side effects and toxicities, dose interruptions, dose reductions, that sort of stuff. And I think that leads me to make one final point before we move on to the next topic, which is the recommended doses in the package or label tend to be different than what we, the folks who treat these tumors day in and day out, use. And this may be a point of education for the broader community listening in, that the 4 weeks on, 2 weeks off, or 3 weeks on, 1 week off for sunitinib and regorafenib respectively frequently leads to a higher toxicity profile. That is, 50 milligrams of sunitinib is poorly tolerated compared to a 37.5 milligram daily dose. For regorafenib, 160 versus 120. And from a pharmacologic standpoint, a continuous dosing schedule may well be more effective in the long run rather than the pulsed dosing schedule. So we all recognize and understand what the label indicates, but the standard practice amongst all of us who treat these tumors all the time is to indeed use sunitinib at 37.5 milligrams continuously daily and regorafenib possibly at 120 milligrams daily orally, which would certainly improve tolerance and not give breaks where the tumor has a chance to repopulate.